Hello and welcome to the American Association of Nurse Assessment Coordination webinar, Countdown to MDS Section GG, Collaboration Between Nursing and Therapy. It is my pleasure to introduce our presenters for today. Amy Franklin, RN, RAC MT, DNS MT, QCP MT, is a Curriculum Development Specialist for AANAC. She has more than 20 years of healthcare service experience. Her past roles in corporate compliance, clinical consultant in multi-states, survey crisis management, director of nursing, infection control, and MDS coordinator has fueled her passion for patient advocacy through sound clinical nurse leadership support. She has spoken as a subject matter expert on clinical and reimbursement issues at regional and national levels. Amy is certified as an AANAC master teacher and an ICD-10 CM-PCS trainer of AHIMA. Her expertise and practice includes extensive knowledge in state and federal regulations, quality assurance, and all governmental payers' reimbursement systems. She is currently devoted to developing and implementing practical, sustainable solutions for clinical and reimbursement systems that will promote high-quality, efficient care. Next up, as Vice President, Legislative Advocacy for Genesis Rehab Services, Joanne Wisely transitioned from serving as Vice President, Regulation and Compliance for the same organization. Joanne has serviced the healthcare spectrum in all acute and post-acute settings as a frontline clinician, an operational manager, a policy developer, and a healthcare administrator. She has participated on CMS and MedPAC technician expert panels and currently serves as the co-chairperson of the Impact Act Implementation Work Group for the National Association for Support of Long-Term Care. And educated at Drexel University, Jane has over 25 years of experience in the acute long-term care settings. Jane has used her healthcare and business background to facilitate design and implementation of electronic medical records since the industry was in its infancy. Jane was instrumental in the creation of nursing libraries and clinical content for the first electronic medical record implement by Kaiser Permanente in 1990. Since then, she has helped healthcare organizations design and apply technology solutions to address critical needs and challenges. With Casamba since inception, Jane is responsible for the vision and development of company clinical strategy. She has an outstanding track record both as a clinician and a product trendsetter. With Jane's innate ability to pinpoint client needs, she is committed to the quality and growth of all products. Today, Jane leverages her strengths in support to current and prospective customers, selecting and deploying solutions that add real value to their organizations. She is an integral part in the position that Casamba holds as the leading integrated EMR provider. A well-thought-out clinical leader in the industry, Jane speaks regularly at industry meetings and she is a member of the national committee that influences healthcare trends and holds nursing certifications in intensive care and case management. When not in the office, Jane can be found mountain biking with her family in California's local Santa Monica mountain trails. So with no further ado, I would like to hand the floor over to our presenters today. It's all yours.
Well, thank you, and I'm excited. This is Amy Franklin, and I'm so appreciative to be with Jane and with Joanne. This is going to be an exciting 45 minutes, and then doing the question and answering that we're very much looking forward to. But we do have some housekeeping things. I do need to make sure that we all understand that Jane, Joanne, and I do not have any financial relationships to disclose, no conflicts of interest disclosed, and we will not be promoting any commercial products and what have you on there. In order to get your 1 credit hour to be rewarded to you, you must participate at least 80% of it. And this is also approved through the ANCC. course, objectives as we run through this all are very much the tip of the iceberg as we look at it. And the whole intent as we get together today is to discuss the collaboration between the therapy, nursing department, and all other ancillary clinicians that may be involved in this new section, GG. As we know, we're not quite clear on a lot of this information, but what we are clear on is that this is about functional abilities and goals, and this all starts on 10-1. Where it originates is where we really want to think about how this all comes about. We get kind of confused as we have these VD, the QRP, the initiatives here, the Medicare spending, and whatnot. What we want to focus on in this presentation is the Impact Act is where this originated from, and from that is the cross-settings of quality measures that are required from the Impact Act. The QRP, or Quality Reporting Program, ignites this section GG. So what we have for us available is that Medicare Part A, original Medicare, are the only ones that are impacted by the Impact Act, if that's not a little funny. And all four of these that you see on your screen are going to be reporting the same information, which would then answer to the quality reporting program. As with anything, new concepts, we ask, okay, who all is involved? What does all of this mean to us at a facility level, at a corporation level? As we go through all of this, our big ideas and thinking about it is first we need to get education. And who does that actually involve would be interdisciplinary team, our direct care staff, but we also have to think about the administration area. So our business office managers, the administrator, our discharge planning, not just with our in-house, but we also have to work outward our pre-planning, our post-planning. So task for the staff just to consider the opportunities to think about who all does this touch, what all do we need to do, and who's going to be that lead educator? Who's going to be the one we're going to go to and answer to? So without further, let's get right into it. A2400 is the key to this. As we know, it's only for original Medicare patients only, and at A2400A is when this will start. So the date that you would put in from October 1 forward is where we would need to focus our attention. And this is what will ignite and open up section GG, as this is what this webinar is about, completing and coordinating it, is the initiation. So A2400A is where we begin, the date, and then as we work through the process in answering and collecting, it would probably start on day 1, day 2, and day 3 as your observation period of that assessment. So consider you open up a 5-day for our original Medicare Part A patients. And then as you fill in A2400, that there would then open up section GG. Then as the patient readies for discharge, you would then create a discharge assessment or a Medicare Part A discharge assessment. There are two different ones, depending on if the patient plans to stay in your facility and no longer receive skilled service. You would open that up, which would then create, with A2400C, the end date, would then open up section GG, and then you would do your discharge. There's some definitions that we have to consider with the GG. So GG, we have the admission, discharge goal, and discharge performance. One of the terminology things that are new to us would be the helper assistance. There is some rules to this, imagine that. We're not allowed to include family or hospice, private duty, student nurses or nurse aides. What we are allowed to do is ask our helpers or our nurse aides, direct care staff, therapists, nurses who are passing meds on the floor, nurse managers, what exactly did happen over the course of the 3 days? Was the patient safe? Was the patient available? Did the activities happen? Did they happen with or without assistance? Then we also work into this very big difference of usual performance. When we were at the QRP training in Atlanta that CMS provided in June, this was a very big discussion, and we're awaiting the REI manual to further help us decide exactly what all this means. But the intent is, as we read and we're trained, is usual performance occurs over the first 3 days of admission. The intent is, how did that patient compare prior to the moment of why they came to us? So before even the hospital stay, what was the patient usually doing? If they were independent with a particular functional assessment area, are they now requiring more help? And is that an opportunity to help that patient improve? So when you think about this, you want to compare the function from the current injury or illness that created them to come to us, and then take a look at our performance with the discharge goal. What's really important with this is to also review with whoever else is involved. If you have therapists involved, now's the time to work with them on usual performance and comparative to where they were at before. One of the key terms that we did hear a lot was baseline status over the course of 3 days. So this is what GG, functional ability and goals, looks like on the start of stay or the start of Medicare Part A only. They've renamed, or the new names mixing has to do with safety and quality of performance. And that just kind of really rings into what we're looking for. So part of the scoring is very different on how you rate a patient. The higher the score, the more independent. The lower the score, the more dependent. So a code 6 is independent, able to do without a helper. A 5 is clean up, set up. But this one has a very unique caveat that you need to pay close attention to. The cleanup part, did the patient start the activity and then needed follow-up? Then when we move into supervision, a code 04, you have to consider this is also touching. This is very different than other types of coding processes that we're used to with respect to MDS. So verbal cueing, touching, steadying, helping the patient, moving them forward. Now we have this terminology to think about: partial and moderate assist. We also have substantial and maximum assist, and then the total dependence. Code 3, when you think about partial and moderate assist, you would want to say less than half the time. A 02 would be more than half the time the helper did the work. This really doesn't have to do about weight bearing. This has to do with performance and how much effort was put forward. Dependent is dependent. The helper does all of the work. And there's a couple of caveats that we'll get to here in a moment. There's 3 new additional concepts to think about when coding, and these are only used when you're completing admission and discharge performance, not discharge goaling. So 07, 09, and 88 are components to where we would rule out why we weren't assessing a certain thing. So one of the issues is the resident refused to even complete or do the task. A 09, you would think about the resident didn't perform it or prior to the current illness, so therefore we're not going to even rate it. And in 88, at the QRP training, they really stressed that we would probably be using this most of the time because it was unsafe or the clinical condition wouldn't allow us to do it. So I envision an example of that would be a patient who has shortness of breath upon even lying down, exacerbation of COPD, and they also have pneumonia. And the patient has, let's say, an amputated leg as well. They never walked. They don't have a prosthetic device, so we wouldn't even rate the walking components. So let's talk about the sections of what we'd be completing upon admission and on discharge, and also our discharge goal. So the admission, the functional abilities, you would have a column that you would fill out. And next to that same column, next to the column, we would also have a discharge goal. So those 2 are being completed after the day 3 observation of usual performance. So we have eating, oral hygiene, and toilet hygiene. These are very distinct, different approaches with definitions compared to other item sets that we have done in the past. So the ability with eating is also putting food in your mouth once the tray arrives. This also includes modified food consistencies as part of that as well. The oral hygiene part is denture management even, and also how they manage the equipment in doing the toothpaste to toothbrush and totally completing that task. Toilet hygiene, you would need to consider, it's not just about the patient doing elimination. This is the functional assessment, or as we would call the abilities for the patient. Managing clothing, completing the task, managing and opening, things of that nature. So this part would be considered self-care. Now we're going to get into mobility, section GG 170. Mobility has a penumbra of different tasks. We have a sit to lying, a lying to sitting on the side of the bed, and we have a sit to stand. We also have chair bed to chair transferring, and then we have toilet transferring. And then also included in 170 mobility, section GG, we also have walk 50 feet with 2 turns, and then we have walk 150 feet, and then we have the wheeling of how the patient wheels if they're in a wheelchair or a scooter, manual or motorized, either way. And then we also have the wheeling, how far do they wheel at 150. One thing to really stress when you're starting your training and the conversations you want to have with your group is a 2-helper rule, helper efforts. If there are 2 helpers in the room physically helping that patient, the patient automatically becomes dependent. In less than half the participation with a 0-3, partial, less than half, the resident performs more than half. They may lift or hold or support the trunk, but more than half, meaning the patient only performs less than half. Do take that in consideration as we run through and learning and helping everybody understand it's about half, more than half, total dependence, things of that nature. So to go more in depth of refusal versus medical and or safety issues of coding these new codes of 07, 09, and 88, one of the concepts here is for us to fully think about when would I use these, 1, and what about a dash, 2. And so the use of these 0, 7, 09, and 88 is at admission performance and discharge performance. As code 7 is referring to the staff did not convince the patient to perform the task, but also part of the investigation as the assessor is it the direct care staff having problems communicating or helping the patient perform? Things for you to kind of think about. And when considering coding 09, it means not available or not applicable. Sorry, not available. So it's not about did not do prior to. So consider remembering comparing back to baseline. What did they do before the acute event occurred to make them come to our facility? And then code 88. This is a patient that you would use that we wouldn't be trialing walking if the patient never walked prior to admission, if they were a stroke patient or they were bedbound prior. So we would use 88 because of the medical condition. A safety concern is that they're totally unstable, and the expectation is that you would definitely be documenting it within the record of why you have an 88 code. I'd like to turn it over now to Joanne.
Thanks, Amy. And so now Amy has gone through a lot of the technical pieces of just exactly how to score. So at this point, we're going to now take a look at the interdisciplinary team, and let's take a look at just exactly what the team needs to consider and how we need to pull that team together. To do that, I think it would be helpful to really go through and review what NDS Section GG required and what it does require versus what it does not require. What it does require is the use of the 6-point scale, and Amy just went through that that's a little different than anything that we're used to up to this point. It also requires that we're going to capture the usual performance of the patient. Not the best, not the worst, but the usual. We'll talk about that a little bit more in a minute. We also have to keep in mind that we're using a 3-day look back. This is something very different from what we're used to in the PPS look back period. And it does require evidence of interdisciplinary team collaboration. And that means that we include rehab when rehab is involved. And that's something, again, that we have to really talk through. And I know that's been a question area for a number of people. Section GG does not use the rule of 3. So that's something that for anyone involved in contributing to the assessment, the performance assessment or the goal setting, we need to keep in mind that it does not use the rule of 3. It does not have a 7-day look back. It basically has a 3-day look back. So that's very different. It does not require a rehab evaluation and goals. And although a lot of what sounds like rehab, being mobility and self-care, sounds like rehab, kind of looks like rehab, the reality of it is it does not require rehab. And it does not require rehab days and minutes. So although it is an MDS section, it will be within that first week, which is going to overlap with your 7-day look back for PPS. The truth is it does not require days and minutes, just like Section O does for service delivery. So how do you pull this group together? Well, we have to think of it from a collaborative effort of the entire group working in the facility over a 24-hour period for 3 days. So that's at admission, and it's also at the time of discharge. We're going to look at the performance of the patient, and then we're also, when it comes to the admission piece, we also have to set a goal of what we think that patient's going to be able to do at the time of the end of the Medicare Part A stay. And that's important to keep in mind, especially when you do have rehab involved, and we'll talk about that in a minute. Nursing all shifts really needs to contribute information as to the usual performance. And that means that we really are expecting, and what CMS has explained to us, is that they're expecting to see evidence in the medical record of what exactly nursing has observed in the mobility and self-care of that patient throughout the 24-hour period. So that means that all shifts. So the observations of what nurses have observed during medication passing or during treatments with respect to the patient's overall function, and in this particular instance, mobility and self-care. Your direct care staff are going to really provide an immense amount of information because these are the people who are working with the patient overall on mobility and bathing and dressing and eating. The direct care staff are going to be involved with the patient to a large extent, and we'll need to figure a way, somehow we need to figure a way of getting their contributions into that overall assessment of performance and then setting the goal. When rehab has been involved and is ordered into the case and is involved during the first 3 days, you definitely need to get rehab input. And when rehab is treating during the last 3 days of the Med-A stay, rehab needs to be included as well. But we have to keep in mind that what rehab sees and what rehab does is really creating a snapshot of information on that patient. Rehab, by nature, has to really assess the patient's overall capabilities at that time, but also really push to the limits to be able to estimate and to assess and to plan goals for the time of discharge. And in some instances, that means it will be discharged outside that Med-A stay. There are times that the patient will be ending their rehab course of treatment after the Med-A stay. So how do we do this? Well, really what we did is in preparing for this session, we really talked about who are the major contributors. And the major contributors are really the nursing team, the direct care staff, and that could be any direct care staff. It could be CNAs. You could have your recreation staff, you could have your dietary staff. Just about anyone could be contributing depending on the patient and just exactly what type of information and what their responsibilities are in any facility. Rehab, as we discussed, when rehab has been ordered in and has information to contribute, and social services, because what we have found in working through this is that Section GG really needs us to know what that patient's plan is for discharge and for the end of their Med-A stay when you really get started assessing that patient at the beginning of their Med-A stay. So how do we take on, just exactly what do we do at this point? What kinds of considerations? Well, what we came up with is having us look at, and what we recommend for all of you to do, is to take a look at the processes and systems that you have within your respective facilities at this time. Do you have efficient and accurate processes with respect to gathering 3-day information? Would you be able, if necessary today, to capture information on your patient's on your patient's capabilities or performance at a 3-day or 72-hour point? What team members are available today, even for your 5-day PPS, to gather the information that you would need for this type of assessment, for the Section GG performance and for goal setting? And would the team members that you have today be able to define and explain the difference between usual performance over a 24-hour period versus the rule of 3 that we're very accustomed to with the MDS? Does the nursing documentation today address patient mobility and self-care? And if not, what can be done about that, and how can that evidence in the medical record be developed? And who is going to gather, and how do you get the evaluation information from rehab? Even if rehab completes an evaluation, whether it be PT or OT or SLP, to complete the evaluation on day 1, how quickly can you get that information? And at what point do you have enough information from rehab to really be a contributor to the assessment of performance and the goal setting? If you as we went through that list, if you see or know of any gaps you may have in your system, you may need to consider some of these options. And what we came up with were these. Look at the NDS information capture that you have today. If that's working for you and it works like a well-oiled machine, can you scale it back to a 3-day capture, just like you do a 5-day capture or a 7-day capture? Do you have a stand-up meeting where the sharing of this information could be done right after that, the following day, so that if you have the day 1 information, you can capture to stand up on day 2? During shift change, what type of content is being shared, and do you have the opportunity to add the observations from one shift to another regarding the patient's mobility and self-care? Does the medical record documentation include any references from any of the shifts at this point on mobility and self-care? Is there a restorative program in your facility? And these people are so very accustomed to working with people all day, every day. Maybe they can help with some of the performance assessment and in contributing to their thoughts regarding goals. Do you have a team meeting that might be a 72-hour meeting or a 3-day meeting or a huddle or whatever you might want to call it that would allow for this type of information to be shared before you would have to be doing your PPS assessment? And do you have the opportunity within your organization to have an electronic communication process? If you do, then is there something in there that you could use to be able to communicate this among the team members that you just selected? And if all else fails, we all know that we very often have to resort to the real-life world of hard copy, and that's the data capture worksheet. If you have something, great. Can you tweak it? Can you make it work for Section GG? If not, we have developed a data capture worksheet that will be in the resources section from this session, And it might be something that you would want to take a look at and really consider for use as far as capturing the information during the assessment period from all the team members. So now that we have captured that information, now what we really need to do is start to set the goal. And I know a lot of people are concerned about setting the goal, but if you have the information for the data capture, the setting the goal will become natural. As we talked about before, you're going to get lots of different information from lots of different members within the team. If you look at this particular slide, and we have nursing with the assessment findings and their observations at MedPass and during treatment, that should be quite a bit to be able to give you an idea of performance from a nursing perspective. Then we overlay that with the direct care information for performance during daily activities and what their mobility is with or without devices. Is that patient who came in with a walker actually using their walker when they go from the bedroom to the bathroom? And overall needs of a helper. And Amy talked about what exactly a helper was and what that constituted, and how often do they need a helper, and does it change throughout the day, so that's going to have to be factored in to that usual performance and that plan for that goal. Rehab, as I said, rehab will have a snapshot. Rehab actually provides a snapshot of information during that evaluation period and during the treatment period. But what rehab will bring to that is the expertise of being able to say, I was able to have this person do this so that as far as setting a goal, I'm comfortable setting a goal for this person at this level. Now, for the other members on the team, do you think that's a realistic expectation? So this is where the real collaboration comes in. And as we said before, social services really needs to capture what the patient and the family expects of this patient at the time of discharge, or in this case, the end of the Med-A stay. And that will weigh heavily in your decision as to what to do and how to set that goal for that patient as far as for your Section GG goals. So let's take a quick scenario, and we're going to run through a scenario rather quickly of what nursing observations were from day 1, 2, and 3. And this is not carved in stone. This is nothing more than just an example. The nursing realizes the patient is unable to complete meals without feeder assistance. They need assistance to stand and unable to walk, and needs reminders and cues to follow direction. The direct care staff says that the patient needs one-person assistance to transfer from bed to wheelchair. Needs helper to push the wheelchair, which means the patient really can't propel their wheelchair by themselves. And needs assistance to clean self and adjust clothes when toileting. And this speaks to the specifics that Amy was talking about. It isn't just a case of being able to go to the bathroom, but also what the self-care needs are of adjusting clothes and self-cleansing at the time of elimination. Again, there are some resources in the toolkit that we're providing for you. So there are some ideas there as far as being able to document this information and capture that information. We also have the opportunity in this particular case, and this is just an example, where we have admission orders for PT. So the PT was able to evaluate the patient on day 2 and treat the patient on day 3. Based on that evaluation and the one treatment, the PT it says that the patient has a chair-to-bed transfer or toilet transfer from the chair of assistive 2. To stand needs assistance of 1. So the PT's goals, and this is only one of the goals that the PT would be setting, would be sit to stand for 60 seconds independently, chair-to-bed transfer and toilet transfer supervision with some verbal cues. Now, Amy talked about how that would be scored if we were scoring that right on the NBS, but we're not because, again, we're working together to set a goal as far as the patient is concerned. We've kind of worked out a little decision process that might work for you. Basically, you take the observations of usual performance from day 1, 2, and 3 from all members of the team, including rehab, And you have the performance reported by a PT during the evaluation and the treatment. And if they are reasonably close, they sound like, if you were talking about this one patient, they sounded like the same person, life is good, and you can move on to the decision-making process for the goal. But if you find a major discrepancy between what the rest of the team is seeing and what PT was seeing, that's the time to really huddle and have an interdisciplinary conversation about exactly what the usual performance is for this patient and what the goal really needs to be. So let's say that we have the information now, and now the next step in this process is to double check with social services to find out what the discharge plan is, keeping in mind that the PT goals may extend beyond the Med-A stay, but social services is also looking at beyond the Med-A stay and at the end of the Med-A stay. And there will be times that there will be a difference between those two, and that needs to be factored into this. Is the patient motivated to achieve greater mobility and independence? And does the patient appear to have potential for increased mobility and independent care? If you have answers to all of those that make sense to all of you, now you can set the goal. In this example, what we said was, with rehab being involved, there was a goal that was set, and remember, we are setting at least one goal for the patient to meet compliance. The goal here was chair-to-bed transfer with supervision. Everyone on the team was comfortable setting that as the goal. But let's take a look at what might happen if you don't have PT's input. And in this case, we don't have the OT, we don't have OT input because we're still waiting for the orders from admission for OT. In a case like that, we wouldn't have any rehab input at all. So the nursing and the daily care team and the social services are going to have to really come up with a goal on their own. Certainly they can consult with rehab, but based on what their observations are and what they have seen and what they feel that patient's capabilities are, we have chair-to-bed transfer with the system one. Well, that's a little different from what it was with rehab. So the question has to be raised. We have the same patient with different goals? Yes. And that is perfectly fine. Reality is that rehab is not always going to be ordered to come in on the case right away, nor are you always going to have rehab at the end of the Med-A stay. It depends on where that patient's coverage is, where you are in the overall Med-A assessment and the coverage of that patient's how much coverage the patient still has. And we also have to factor into this that historically nursing assessments do not fit goals. So when you put those factors together, we know and we realize that right now there may be some gaps in the systems or some concerns. It's July. We would only have to do this until October 1st. So what we would suggest to you and really strongly recommend is to take a hard look at the systems in place regarding rehab admission orders. If you feel that you have a population in your facility that most of the time needs rehab and most of the time rehab is going to have to be involved, do you have a process for admission orders so that you will be able to capture the rehab input in time for that 72 hours or that 3-day assessment? Do you currently have prompt and effective communication with the rehab staff? As I mentioned earlier, even when they are ordered in and they do get the eval done, how quickly can you get that information? And if that's not as fast as you think it needs to be, that's a system and a process that really should be worked out now. When the rehab director is away, they're out sick, they're on vacation, they had to leave for an emergency, whatever, do you have a designee? Do you have a point person in that rehab department who can also help you get the information and help with the decision-making process when rehab is part of their active caseload? Do you have a restorative nurse coordinator who could actually help and assist in taking a look at the patient and give that restorative type of perspective on what that patient's capabilities are and what they might be capable of doing a few weeks out or whenever the end of the Med-A stay would be? So if all of these are kind of thoughts that you know that you need some work, my suggestion would be that you might try to plan to practice setting some discharge goals and work with your rehab department now and test the system. See how well, test yourself and see how well you really are doing and whether you're all comfortable with the types of goals that are being set. And now that you had some of the technicalities from Amy as far as the specifics of filling in the MDS, and you have some ideas and some of our recommendations with respect to how to make all the pieces come together, I'm going to turn it over to Jane to really show you some of the specifics about the teamwork and some of the other considerations that we came up to. Jane?
Thanks, Joanne. Excellent illustration, and there's some great points. So how do we go from our worry and concern to a workflow that makes sense and can really be accomplished by the team? Well, first of all, let's review who contributes again. While the nurse assessment coordinator is a likely person to complete this section, the usual performance really needs to be determined based on input from everyone on the team who observed that patient over the observation period. This means therapy, of course, if they're involved, but also nursing, the patient, family, social service. The values for this section cannot be decided by a single team member with only a few hours of exposure to the patient over the observation period. Really very important to remember. And we've got some things we need to consider when we complete the section. There's a new observation period. First 3 days of Medicare for the 5-day, last 3 days of Medicare on that Medicare discharge. This section has completely different definitions than G, and the scales are different. GG shows improvement when the number goes up. Section G shows improvement when the number goes down. That could be very confusing, right? Plus, as mentioned, we've got goal setting. We've never set goals before on an MDS. And finally, there's a new assessment that we now have to factor into our already complicated assessment schedule. That's that new Medicare discharge assessment. Let's get started by looking at the new observation period. On our 5-day assessment, most of our section observation periods are ARD minus 6, so a total of 7 days. Section GG's observation period is the first 3 days of Medicare, regardless of the ARD. So we could very well need to consider the patient's functional status for GG on a day that we don't look at all for the rest of that 5-day MDS. So we need some systems in place to be able to start thinking about this right away. Well, we've worked out a little bit of a flow sheet for you. Starting on Med Day 1, you really need to have a process in place where the team can discuss this patient on rounds or care plan meetings or whatever it is that you have in place today where you regularly discuss patients and their plan. You need to observe self-care and mobility and document those findings. Starting on day 1, if there are rehab orders, be sure there are systems in place to discuss the patient with the therapy team, particularly the goals. If you are on the therapy team, evaluate that patient, treat, and collaborate daily with the IDT team for these 3 days. Now, coming on day 2 of Medicare, talk about the patient again. Shift-to-shift report should discuss the patient's self-care and mobility capabilities. Remember, therapy, if involved, may only be observing the patient for a couple of hours. What happened the rest of the day? On day 3, then, continue to gather the information and determine the usual performance based on the team's observation and decide on goals. Get in there and complete Section GG and document your rationales. Do this now on day 3, and don't go back and change this next week or whenever you get around to completing Section G. Remember, this section should look different. Not only is the definition different, rule of 3 versus usual, but the scales and the observation period are different. And based on this, you'll be able to justify your assessment findings and the values in GG. We're going to help you a little bit with that with some tools to help you with that process. So what should you do to make sure you can get the information you need to determine the appropriate values for this section and to also justify your answers? First of all, check that census every day. Now, of course, you do this already, but since you would need to observe the patient for usual performance instead of looking for rule of 3, you'll need to be on top of this. And as we'll discuss later, you need to be sure you know of any patient with an early but planned discharge also, like family decides they're going to take dad home tonight instead of tomorrow. Track all patients during their observation period and discuss them daily with the nursing team and with the IDT team at stand-up or whatever patient care meetings you have in place. If you don't have something in place, you need to think about getting something like that in place. Observe. Be sure all members of the team are observing and documenting the usual status through flowcharting or some other means. Discuss this patient. Every shift change should discuss the patient's usual performance for self-care and mobility as observed by nursing. Be aware and discuss the direct care team's observations, what the family's observing, the medical record, what the patient says, and of course what the therapy team is doing while they're working with the patient. Seems complicated, but we're going to try and get it a little bit more simple for you by providing some tools for you. We know this is a new way of collecting, and so AANAC has put together a collection tool that you can use to practice with now and potentially to use come October. Now, this collection tool has several sections to it. They've provided these forms so that you can collect the data, and they're available in the toolkit resource section that we've got. The form has a section, information plus descriptions, and I'm going to go through and talk about each section. The area that you see in red right now is it maps back to each description in section GG, and it's your collection area. There's a space for each shift for the observation period, and there's an explanation of each section on the right-hand side of the form. This side illustrates the explanation of the scoring for quick reference. Careful here. Remember that our patient improves as the score gets high. This area talks about when you don't assess. Really important that you use these codes if you're not going to assess the area rather than leaving dashes. As you know, or as you may have heard, there's a financial penalty for overuse of dashes. And we're going to talk a little bit more about when it's appropriate to use each of these areas. And we've got our definitions of each of the items here. And so what do? Well, beginning on day one, we start collecting the usual performance, and you do this for each shift. One way to collect this would be to have the house supervisor keep it for PMs and nights, pass it on to the team leader on the day shift, and then collaborate with the rest of the team during stand-ups. Since the usual performance needs to be collected, it will be important to establish a process that facilitates this collection. On day 3, you're going to review your findings, set your values. And I know it's early, but you really should get this information documented in the medical record and actually enter the values on the assessment. This is the temptation to wait in completing this section because you risk losing the true picture of the patient's status for self-care and mobility if you complete this later on when you do section G. All right, so let's say we've completed that 5-day. And now what do we do when the resident comes off of Medicare? Similar kind of process. When the end of the Medicare stay is known, count back 3 days and begin observing for usual performance for self-care and mobility. Of course, we always have nursing and direct care staff, plus our social service team. We may or may not have therapy. Be prepared for that. And be sure to discuss this patient at your team meetings and care plan meetings too. This discharge from Medicare assessment, it's a new requirement. Don't forget about it. Collaborate as a team to determine your final content and scores and document your findings in the medical record and in section GG. The collection tool can be used for that too. Discussing this patient at IDT meetings will be an important addition to your process. Okay, so now we've got a process in place to collect the information. But since you'll be consolidating the information from many sources, you'll need to be sure to document the rationale for the values that were actually entered in section GG. This slide illustrates a documentation template. If you don't use this one, I recommend that you come up with something you can use to justify your section GG values in the medical record. This will allow your facility team to confidently respond to queries on not only the values you selected, but the rationale for values that were not assessed. So you'll chart that based on chart review, direct observation, discussion with the staff, the patient, the family, over the observation period, that the following areas are the usual performance for self-care and mobility. And it might look something like this. Section GG completed today, based on chart review, direct care observation, discussion, and so on. This is the usual performance for self-care and mobility. Get it down and get it in the record. Now, what about those items that were not assessed? First of all, remember, don't use dashes. There is a significant financial penalty if you use dashes. Plus, there's probably a reason code to cover you for areas you're not assessing. As long as you document why you're not assessing an area, you are justified in using one of these codes. So, for example, got a patient short of breath on exertion, had a recent discharge from the acute setting because of an exacerbation of CHF, and we've got some complications with diabetes. We're not going to assess these items. We've got an unstable medical condition. So in this case, you're not going to assess the areas, and this is appropriate. Your critical thinking and confident nursing judgment justifies your reasoning. Now, let's talk about goal setting. Well, there are 3 types of goals. We learned a lot about this in the CMS training. We've got goals where we expect an improvement. The team expects to see gains in functions by discharge in the following areas. Of course, there are some times when we provide skilled services to a medically complex patient and we're not really expecting progress to a higher level of functioning. The goal value in this case would be the same as the usual performance. And finally, we may see patients that qualify for skilled services, and while we might slow declines in function, we're not going to prevent it. In these cases, that goal value might actually reflect a decline in self-care or mobility. At this point, we know we're only required to set a goal in one of the functional and self-care areas. And this is one of the areas where we're hoping for further clarification on exactly how to complete this section in the upcoming RAI manual. So there will be more to follow on how to set goals up if you're only going to goal for one item and what to do with the other items. So an example, using my same patient recovering from that acute exacerbation, I document my rationale for goal setting for the areas that were assessed. It's important to note goals should not be completed for areas that were not assessed. So since the mobility items were not assessed due to my patient's unstable medical condition, I don't set goals for these. So we've walked through the process of collecting the data, we've discussed how and when to complete the sections, and we've talked about how to confidently document our decision so we can justify the rationale for the values in this section. And it's a lot to think about. Are there any shortcuts or tools that can help us? What about the EMR or the MDS or therapy software that we're all using? Can these help? Well, let's talk about it. First of all, your EMR might be capable of adding a custom charting area or an assessment for GG. And that's a great feature. If that exists, I would absolutely use that. But it's important to remember that there might be other members of the team that don't use that tool. So be sure if you have something like that, that you reach out to the other members of the IDT team that may not have access to the software and get their collaborative contributions as well. Second point, you might have software with a functional assessment area that is capable of averaging. In other words, taking all the values entered over the 72 hours and through some sort of algorithm coming up with what that software determines as the usual. That could also be a great feature, provided, of course, that everybody's contributing. You need to be sure you carefully review any items where software averaged or calculated values for you. Because remember, you're attesting to the accuracy of this section, and it's your responsibility. And then finally, your software might be capable of actually sending values. For example, your therapy software may be capable of setting what the evaluating or treating therapist has set for the usual performance in the therapy department for section GG and also for the goals. Like any other section that you fetch from any external source, you want to use caution and carefully review those sections. Remember, in a 72-hour period for a patient, therapy might be involved for 3.5, 4 hours. What happened to the other 67, 68 hours of the patient's usual performance? So it's very, very important that if you have these tools, you use them in a smart way. Accuracy in this section is auditable. Be sure you have the proper substantiating documentation to support or justify the answers that you actually completed and sent off with this assessment. Boy, it's a lot to think about. But with planning and the correct team collaboration, you'll be ready for this new requirement. And with that, I'm going to go ahead and pass that mic back to Amy.
Well, lots of things to think about, lots of things to collaborate. And we're working with the NASL crew on getting this together and thinking about exactly what we want to do and how to synthesize this at the facility level or at your organizational level. Here's a list of questions that we talked about. And again, this has to start on 10/1/2016. Medicare original Medicare. Medicare Advantage is not part of this at this time. So a Medicare Part A patient that starts 10/1, that's the requirement. Some other things to think about: start now. Train, test, and tweak. We have a toolkit associated with that. We also have a list of resources that we utilize and that we really encourage you guys to take a look at. Don't forget your handout list. And I'm going to turn this back over to our moderator because we want to get to your questions as soon as we can. We so appreciate the opportunity we're going to be having with you for question and answering time.
Hi, I'm going to offer a couple questions to our presenters. We seem to be receiving a number of questions about Friday admits and also just exactly the universe of patients that Section GG covers. Skilled patients, as Amy just mentioned, Medicare Part A patients, but not Medicare Advantage. Would one of the presenters address kind of the scenario for a patient that comes in admitted on a Friday night and when the assessment would have to occur?
This is Amy. Go ahead, Jane.
Okay, great. It's based on the first day of Medicare. So on a Friday admission, heads in the bed at midnight, that's day one. And when we talk about when our anchor date for 10/1 is, while we don't have full clarification on this, we do believe that it'll be the Medicare start date on 10/1 and after where you'll have to complete this. So if the Medicare start date was prior to 10/1, you would not complete this section on discharge. So for your Friday patient, after 10/1, Friday's day 1, Saturday's day 2, Sunday's day 3. That's the end day for that 3-day observation period.
Moderator, do we have time for another question?
I believe that is all the time we do have for questions today, but just a note to our audience, we will try to answer as many of these as possible in a frequently asked questions document for you, and we will provide that to everyone who attended today. We would like to thank you all for joining today's webinar brought to you by AANAC and NASL. In just a moment, you will be seeing a survey on your screen. We ask that you take a moment to fill this out as it does help us better plan future programming. Again, thank you all very much for joining us, and a big thank you to our presenters for sharing their expertise. We thank you for all of your questions and time today. We look forward to seeing you online next time, and you may now disconnect.